is Focus with Jack Caudill.
Good evening, I'm Jack Caudill. Welcome to this month's edition of Focus. This month we're talking about breast cancer, as October is Breast Cancer Awareness Month. Two guests with us to talk about that. Dr. Joel Brink, he is a diagnostic radiologist with Monument Health, and Dr. Nick Czosnyka, he is a general surgeon with Monument Health based out of Spearfish. A little background again, October is Breast Cancer Awareness Month. The CDC says that female breast cancer has the highest rate of new cancer cases of any cancer, with just under 130 cases per 100,000 women. Also, they say it has the second rate of cancer deaths among all cancers. And the American Cancer Society says more than 287,000 new cases of invasive breast cancer will be diagnosed in women this year in the U.S., and they say 1 in 8 women will develop breast cancer at some point in their lifetime. Dr. Brink, we'll talk to you. We're talking about Breast Cancer Awareness Month. How important is it to raise that awareness of something that maybe not everybody is thinking about?
Yeah, absolutely. So I think the big number you said there is 1 in 8 women are going to get breast cancer throughout their life. That is a staggering number. And the biggest thing about breast cancer is if we find it early, most of the time women can go on and have a great life and not really have it affect them in a major way. So it's very, very important that we find it early. And the best way to do that is obviously screening. So. And
Dr. Czosnyka, as you look at it, why is it so important to get awareness of breast cancer out there amongst people?
Well, like Dr. Brink was saying, breast cancer diagnosed early has an extremely high likelihood of being treated to a cure, right? If we have an early breast cancer, let's say a stage 1 breast cancer that's treated completely, there's a greater than 99% chance that woman is still alive and having a meaningful life 5 years after her treatments, right? So essentially, can beat the cancer and survive as if she never had cancer, perhaps. So,
what exactly is breast cancer?
Yeah, so we all have breast tissue, right? This is glandular tissue. For women, we all see how breasts are used in childbearing and breastfeeding, but that glandular tissue has different cell types, and the cells can have basically genetic mistakes happen, whether that would be spontaneously or due to a familial inherited genetic trait that can lead to the cells essentially going haywire and growing out of control and becoming a cancer.
Are there different types of breast cancer? Is it just one, or do we have a lot of varieties of what you're doing?
Yeah, there are different types, and again, it gets down to that cellular level, like what type of cell in the breast, whether this would be a ductal origin or whether this is a stromal origin. These are different types of cells that the breast is made up of.
Now we're talking about early detection. You are a radiologist, so that is your thing, is early detection. How important is that? How much difference can it make, early detection, from waiting 6 months, a year, 2 years, 3 years down the road?
That's a great question, and it makes a huge difference. And especially, most times when women come in and we find an early breast cancer, the stage 1 that he was talking about, they cannot feel it within their breast at that point. If a patient's waiting until they can actually feel something in their breast, oftentimes it's a later stage cancer. So if we can find it early before the patient can feel it or anybody else can feel it, they have a much higher chance of going on and having that 5-year survival greater than 99% that he was talking about. So it's extremely important.
What's that timetable? When do women start these screenings? What kind of screenings are there?
Well, and that's a really confusing question at times on who you ask. Most of us that work here in the community, surgeons, radiologists, the recommendation is that people start at the age of 40. That's been shown the best age to start screening mammography, and then doing it once every year after that.
And how is that advanced when you look at detection and you look at screening and what kind of tests that you guys can do? Is that advanced along with the rest of medicine, where you were able to do a whole lot more now than you were 10 years ago?
Absolutely. The technology is getting better and better, and I've been really happy to partner with all of our local institutions throughout here, to the point that everybody in the Black Hills now actually has what's called 3D mammography or tomosynthesis, which is by far the most up-to-date form of breast imaging that we have for screening. And so all of the institutions throughout the hills actually have that technology now, which is spectacular, but also additional imaging. Ultrasound is better than it ever has been. Breast MRI is also came out now that we're very good at looking at extent of disease and stuff like that.
So how do you get women over that hump to convince them that, okay, I got to go do this for the first time?
Yep, that's a really good thing. And to be honest with you, the group of girlfriends is probably the best thing you can do. A lot of people have anxiety about that first time. We have a lot of groups of women that come in with their friends or their sister or something like that. They come in, usually a screening examination is 10 to 15 minutes. Then they go get lunch and mimosas afterwards and make a day of it. So it's just not very long to get in. And just go ahead and make a day of it, go out and have some lunch afterwards.
All right, that's not a bad idea. Go
Yeah.
have a party on that. Dr. Czosnyka, you deal with this once you get to the surgical side of it. How much difference do you see from someone who has had early detection for somebody that has let it go for a year or two or even longer
Yep.
for dealing with it surgically?
Yep, it is an enormous difference. When we talk about surgery for breast cancer, we're trying to remove the cancer entirely, right? What we discuss as negative margins, and we're trying to also clinically stage the breast cancer when we remove what are called lymph nodes underneath the underarm to answer definitively, has this cancer spread anywhere? Sometimes we can get a good sense of that through imaging and through physical exam, but a lot of times we actually need to sample the lymph nodes underneath the arm to know whether or not the cancer has spread there. And so an early cancer that's physically small in size and has not spread to the lymph nodes can usually be removed through a very small incision, maybe 2 inches, have very little cosmetic alteration to the breast once the surgery is completed. And then that sampling of the lymph nodes can also happen through a very small incision right on underneath the axillary hairline, both of which are often not very noticeable a few years down the road.
Now, we talked about the advances in imaging that have happened over the last few years. How much more can you do surgically than you could not so long ago?
Well, I think the best answer there is what we've learned is we can do less surgically. We have to do less, meaning maybe if you look back 30 years and you maybe have your grandma who had a very invasive surgery, what we'd call a radical mastectomy or removal of her entire breast and all the lymph nodes underneath the armpit. What we've found is that's not necessary all the time anymore, and many times, if not all the time, it's preferable to avoid that. Now, there are certain situations where more surgery is still needed, but again, back to that early stage cancer, most of the time we can do what's called breast conserving therapy or successfully remove all the cancer through what's called a lumpectomy or a very small removal of just the area of the breast that has the cancer in it.
So how much difference does that make for the woman who's having the surgery that you don't have to go to that radical end like you did before?
An enormous difference. One, it's a same day surgery where you're having the surgery, leaving, going home the same day. The morbidity or the complications that can come from surgery, whether that would be possibility of a wound infection or fluid filling underneath the area where the surgery took place or a nerve injury perhaps, those can be greatly reduced by just having to do less surgery, less disruption of the tissues.
Psychologically, what difference does that make to them?
Oh, that's also a huge difference, right? To maintain your natural cosmetic appearance or nearly normal for you is a huge benefit to patients. And so everybody's different. Their decision is theirs, and we're there to help them navigate that decision. But I would say the vast majority of women choose, if it's the right clinical decision, they would choose the less invasive surgery, that breast conserving option.
All right, we got to take a break. We'll continue our look at Breast Cancer Awareness Month when we continue with this month's edition of Focus. And good evening, I'm Jack Caudill. Welcome back to this month's edition of Focus, talking about Breast Cancer Awareness Month, which is in October. Dr. Nick Czosnyka is a general surgeon with Monument Health. You do this surgically, but that's certainly just one of the treatment options when you deal with breast cancer. What are the other treatment options that are out there, and what kind of progress is being made over time?
Yeah, so that's a great topic, the general idea of comprehensive breast care. especially when it comes to breast cancer. As a surgeon, I play one role, and that's the technical side of surgery, but we have radiation oncologists that often play a major role, meaning the application of radiation to the breast tissue. And then there's medical oncologists that play the role of potentially prescribing chemotherapy or some different therapies that may come after a surgery is completed. And so it is a team approach, right? These are not my areas of expertise, so what I would say is what we've seen in terms of medical oncology is there has been the potential application of chemotherapy before surgery that can help take a more advanced cancer and shrink that down to a place where then maybe surgery can be applied in that more minimally invasive way, that breast conserving therapy, type therapy. And then there's also the post-surgical side of medical oncology where we've found that we can know more about the cancers and therefore how they'll behave once surgery is done, and we're more in that time frame of survivorship where you're saying, okay, is this going to come back? And if it is, would you be a candidate for perhaps chemotherapy after you're done with surgery?
And how much do you all work together? That, okay, you're going to do the chemo, then you're going to do the chemo radiation, now you're going to do the surgery. How much is that a whole planned sequence of events?
We work very closely together. So every Tuesday we meet for what we call a Tumor Board, and this is a time to collaborate and take a few minutes to maybe 10 minutes for each case and say, okay, we've got the radiologist here, we've got the pathologist here, the medical, radiation, surgical oncology teams here. And we're going to present your case and we're going to say, do we all agree? What is the best next step? Maybe the plan I've laid out surgically would be put on pause for a second if Dr. Brink were to say, hey, but I looked at that MRI and I see there's another area in question, and now maybe that changes how we go about approaching it. So by taking that little bit of time to really say, hey, is everyone thinking about this in the same way, is very, very helpful.
And Dr. Joel Brink is a diagnostic radiologist at Monument Health. You talked earlier about that timetable can get complicated if somebody has risk factors or is prone to that. What are the risk factors that people should know about and think about and kind of keep in their mind?
Yeah, probably the most obvious one is family history. If your family has quite a bit of breast cancer in their family, it's possibly that you have an increased risk of it yourself. So I think that's something that's really important to talk to your primary doc about, whether that's family practice or obstetrician, gynecologist. But really, just kind of let them understand your family history. There's actually several tools out there that you can actually get a lifetime risk assessment, and it'll actually give you a number of what your lifetime risk of cancer is. And that takes into several different things, how many children you've ever had, have been pregnant, stuff like that, but then also family history in there also. So that's very helpful in kind of realizing where you're at in the risk stratification.
How much does genetic testing play into all of that these days?
Genetic testing is becoming very, very big and very, very popular. And so a lot of these patients that are at a slightly higher risk, they do actually start qualifying for doing genetic testing. There's multiple different genetic mutations out there that can lead to a higher risk of breast cancer. And so there's multiple panels that they'll run on these genetic tests if you have an increased risk. And in those individuals, sometimes they might actually be seeing a surgeon, every year to be evaluated, or, if some of the genetic mutations can have up to an 80% lifetime, risk of breast cancer. So they might actually go through prophylactic surgery to actually prevent that from ever creating before. So we're learning more and more as we go on, and it's very, very important as we continue forward.
How about warning signs? What should a woman look out for when they see this or that to realize, I need to go talk to somebody?
Yep. So obviously, I'm still a big proponent of monthly self-breast exams, and basically just kind of becoming knowledgeable how your breasts feel. If you feel something new, check it in another week or two and see if that's changing or not. If it's not changing, then we recommend you go see your primary care physician and have them do a breast exam also. And then if they're concerned about it, then we'll definitely start taking a look and make sure to do some imaging and see what we see there. So.
Is it sometimes a challenge if women feel that there is a problem to get them to deal with it and go, or actually go and get looked at and get treated?
Yeah, I'd say the hardest thing is anything that is self-discovered is anxiety provoking, right? So not every lump is a cancer, not every pain is a cancer, not every change is a cancer, but we certainly have to keep vigilant and not ignore things. And so what I would always recommend is if you do notice something new, whether that's a lump, skin changes, nipple changes, whether that's a retraction or kind of a scaly change to the skin, new drainage, what we call discharge, maybe that's bloody or not something you've had for a long period of time or new, that you get it looked at. Go to your primary care doctor, have them evaluate you and kind of get tapped into that process of further evaluation, because it can be more than just a physical exam. Maybe you will need some imaging to really get to the bottom of what's going on.
I'm sure you guys would prefer somebody come in and be wrong than
Absolutely.
stay at home and have been right?
Absolutely.
All right. Looking at some of those risk factors as well, some of the warning signs, is there a way to boost prevention? Can you prevent breast cancer? Is there anything you can do, or is it a factor, if it's coming, it's coming?
Yeah, there actually are. One of the biggest things that actually pushes breast cancer is actually the female hormone estrogen. Avoiding hormone replacement therapy after you go through menopause, decreasing some of that estrogen stimulation is probably one of the best ways to do that. And that also just obviously healthy diet, exercise is big. As we put on a few extra pounds, we have a little bit more estrogen in our system. So exercise, good diet, stuff like that always helps prevent that.
Can things like smoking contribute to breast cancer as well? I know it can, obviously, for lung cancer.
Yeah,
but
smoking has not been directly related to breast cancer in any research that I've read.
All right. We got to take another break, and we'll continue our look at Breast Cancer Awareness Month when we continue with this month's edition of Focus. And welcome back to this month's edition of Focus. I'm Jack Caudill, and October is Breast Cancer Awareness Month. We're talking about that. Dr. Joel Brink is a diagnostic radiologist with Monument Health. We're talking about women and breast cancer. They are the vast majority of cases, but men are not immune to breast cancer. How often do you see that, and what do men need to know about breast cancer?
Yeah, so that's a really good question, and it's not extremely often that we see it. I'd say we see about one case per year here in the Black Hills, but it's a very similar thing that you're looking for women. You're looking for something that's a change in the skin. Do you have a palpable lesion? Usually in men, you're going to feel kind of a palpable lesion. They're easier to feel in a man than it is in a woman, because usually their breasts are much smaller. But if you feel a solid lump that's different than the other side, that'd be a possible concern sign that you should once again go to your primary care doctor.
Do they do the same kind of imaging as women do?
We absolutely do. Yep. So they can go through a mammogram just like a woman does, and we do that actually several times a day, I'd say. But yep, we can do a mammogram, we can do ultrasound, we can do everything that we can with a woman.
How do you get men to take that seriously? I mean, it's got to be.
Yeah. And to be honest with you, they usually take it pretty seriously, but I will tell you they are not as strong as most women getting a mammogram. They complain more. Once we explain it to them, they usually jump right on board and they're okay with it.
And Dr. Nick Czosnyka is a general surgeon with Monument Health out of Spearfish. What does the future hold for the treatment and prevention of breast cancer? Where is all of this going down the road?
Yeah, well, I'd say the trajectory we're on of less surgery, more medical treatment for cancer, almost certainly will be the trajectory that continues. Will surgery ever be completely eliminated? Well, I think that's probably pretty far off, but that would be a great situation, really, if we found the medical treatments and therapies that could basically, have a cancer dissolve and regress completely without surgery. That would be great. I think we're a long way from there, but that trend is what we'll see.
But you see some of the things now, you see immunotherapy. You see some things that are getting absolutely spectacular results. Mm-hmm. Where's that research going? Is there some giant breakthrough sitting out there somewhere?
that there's no question that will be where we go, but I don't see that as an impending just around the corner. No, I'm sorry to say.
Dr. Brink, where do you see the future of all this going down the road?
Yeah, so I think, the big thing I think is we already talked about genetics, some of that stuff, and really trying to hone into very patient-specific care. What makes sense for a woman that's maybe 75 years old without family history might be very different than somebody that's 45 years old and her mom and her grandma had breast cancer. So really trying to hone in on, trying to realize, what the risk factor is, doing very specific risk reductions for those patients or high-risk screenings for those patients that make more sense for her than it would be for a different woman. We're really pushing towards that and then trying to see how we can go very patient-specific with some of our treatments.
Now, you guys just recently opened up the new and improved Cancer Care Institute down here in Rapid City. For a town of this size, how well set up are we to deal with a variety of cancers?
I think we do an amazing job here in the Black Hills. Obviously, we obviously cover a lot of different area. People come into the Black Hills and into Rapid City for treatment, and we have some very well-renowned radiation oncologists, medical oncologists, surgeons. I think we are set up in a stellar position to treat pretty much everything that patients need with here in the hills.
Did you see it? How is treatment set up here? Are we in good shape for an area this size?
I think we are. Obviously we have kind of this hub built around Rapid City, and we've got different clinics that can provide access into the resources that you'd find kind of at this more referral level at the cancer center. But take my practice, for example. I'm based out of Spearfish, but I work extremely closely with the oncologists, the radiologists, et cetera. So though surgery may take place in Spearfish, essentially all of the care that surrounds cancer treatment other than surgery is going to take place in Rapid City. So it's really more of like an extension than a separate entity.
Are there any trends in this area that you see that stand out when it comes to cancer care and cancer detection and cancer cases?
Well, my practice is so focused on breast cancer, and then, as a general surgeon, I participate in the treatment of colon cancer as well, and limited skin cancer care. I'm sure there are, advances that are taking place in other fronts. Maybe Joel could speak a little bit more. You probably see a little bit more broadly the different areas.
I think one of the biggest things that I see as a huge benefit is, once again, as Dr. Nick talked about, the Tumor Board is having a very open communication between all the different specialties that are involved in the patient's care. So we go over every single patient. So we have pathology, radiation oncology, medical oncology, radiology, and surgery all in a room, and we all talk about every single patient. And if there's ever a case that's extremely difficult or questionable, we also are directly connected to the Mayo Clinic. And so we can always send out a consult to them and say, what would you do in this situation? Usually within a couple of days, they'll respond back to us and say, hey, you guys are right on track. That you're doing the right thing. Or they'd be like, well, maybe you should consider this. So
on that, we have run out of time. So
all right.
Dr. Joel Brink, Dr. Nick Czosnyka, thank you both for coming up. Thank you for joining us for this month's edition of Focus. See you again the first Sunday night of next month.